Welcome to this session, ERS Highlights. I'm sorry that the audience is not that large, but doesn't matter. We have put together a very high-level panel of ERS experts on non-TB respiratory diseases and topics, and I'm very happy to co-chair the session with Peter Cavalli. Peter is very famous, and I don't think needs to be presented very much. At the present, among other things, is chairing the COPD committee within the European Respiratory Society.
We're going to change the order of the presentation slightly. Our first speaker will be Professor Ashley Woodcock, who's Professor of Respiratory Medicine in the University of Manchester, and a very old friend, at least of mine. And he has done terrific things in developing respiratory medicine in Manchester. And amongst his many talents, he's developed a specific interest in the management and understanding of chronic cough. Indeed, for those keen readers of journals, you'll see in a review article which Jackie Smith, his colleague Jackie Smith and Ashley did in the New England Journal of Medicine only last week. And therefore, unsurprisingly, Ashley's going to talk to us about tackling cough.
Thank you, Peter. Did you walk here today from home, was that right?
I use the train.
Thanks very much, and thanks for the introduction. Much of the work that I'm going to be talking about is indeed done jointly initially with Jackie, and she's now, I think, world leading in cough. And of course, I come here with a certain swagger after our New England Journal paper, so thanks very much. It's a culmination of probably 10 or 15 years of work, during which I think our understanding of cough has really changed. I want to tell you about a group of patients who have been, I think, not well served by medicine, and how our thinking about them's changed, and as a result, new therapies are coming. First of all, my conflict of interests. Part of the thing we do here is to measure cough sounds and therefore count cough objectively for new therapies. And I'm a co-inventor. I've never earned any money, and I never will from this. So the plan for the talk is to give you a strategy for managing chronic cough, a 4-step guide, provide you a new concept in the etiology of chronic cough, that of cough hyperresponsiveness, and tell you about progress in understanding mechanisms and treatments. So first of all, chronic cough is by some distance, the commonest cause for which patients seek help from doctors. This is US data, but it's way more than many other common symptoms. They go with cough. The classification of cough is typically this: acute cough, we all get after colds. Subacute cough, really quite common, a cough that goes on after a viral infection and then fades away. And chronic cough, which is defined as a cough going on for more than 8 weeks. First, the cause in the first group typically ascribed to infections. This post-viral thing, it's probably very similar to chronic cough, but just not lasting as long. And then chronic cough, which for about the last 20 or 30 years has been described as being caused, and I do mean caused, by asthma, nasal disease, and reflux disease. And the mantra that's been out there is that if you only treat patients for those conditions, their cough will go away. And if you look at all the early studies on this area, particularly from Richard Irwin in the United States, his people used to go across and see him in the United States, and he was talking about success rates of 97% from the strategy that addressed these 3 conditions. Cough is very prevalent in the community, and if you look at this area down the bottom here, cough occurring once a week or once a day or more, 12% of patients have chronic cough, and 7% of patients at any one time say they have a cough that's disruptive to their lives. So it's a very common condition. Typical case history from a patient like this is it's a woman, as I'll show you. It's a dry cough typically that goes on for many years. They drive their partners crazy. For women, it's a dreadful condition. 50% of the patients who come to our clinics sat on incontinence pads. Typically triggered by changes in temperature, perfumes, and dry foods. And they've had loads of treatments. Very often they've seen lots of specialists. They amble around ENT to gastro to respiratory and so on. They're often very fed up. This is the data on gender and age, and you can see the females in red, much more common, about twice as common in females and males, typical peaking around 50s to 60s. The influence of cough on their lives is extensive. First of all, physical, causes exhaustion. Cough syncope is a real issue, particularly for drivers of lorries, for example. Causes urinary incontinence and vomiting. Socially, it's difficult, causes absenteeism, affects the marriage, people can't go to concerts and so on. And they just become frustrated and angry and depressed. So it's quite an impact on their lives. So what are the neuronal pathways that control cough? Typically, patients report this sense of throat irritation, that tickle, that irritating tickle we all get after a cold sometimes, but it's persistent. And that throat irritation drives the urge to cough. The sensation comes from the airways. It's transmitted up the vagus through jugular and nodose fibers to the NTS, the cough center in the brain. And when that's stimulated, that pattern happens and they cough. And cough produces this sort of sense of temporary relief of that symptom, but it comes back again within a short time. We knew very little really about innovation in humans until very recently. We knew that there were two sorts of innovations in guinea pig. There's this C-fiber network of nerves and A-delta fibers, which are mechanically sensitive, have this arborizing tree display. This is original work by Brendan Canning in the United States. And we didn't really know whether the situation was the same or different in humans until our own lab recently have produced this data showing very similar patterns. And we searched for ages. These are quite sparse. The other thing about, about nerves is that they atrophy very quickly. These are samples that are snap frozen, and that's the only way you can get these. And we now have very nice three-dimensional structures of these nerves. We have very similar innovation. So these are the C-fiber terminals, this network, and typically they have TRPV1 receptors on them, responding to capsaicin, which was that one there, which flashed by very quickly. That's chili pepper extract. But a whole bunch of other receptors, as you'll see, which are quite important. TRPA1, and I would point out P2X3, which is also on C fibers. Also acid scenting. So all these things, TRPA1 does tobacco smoke and irritants. And then A-delta fibers here, which are acid sensing, also detect mechanical things like sputum, and they have, sorry, if I could just go back, TRPV1, pressing the wrong buttons, TRPV4, and sodium potassium ATPase as they're on their terminals. What we think happens in patients with chronic cough is that these A delta fibers undergo phenotypic switching, which is probably permanent, so that they start to have some of the receptor patterns on these nerves that they have on here. So what should you do if you see a patient? Exclude and treat the obvious, investigate and treat common triggers, make sure you're not missing rare things, and then think about treating the cough in the end. So the obvious, history examination, chest x-ray, spirometry, red flag, anybody coughing up blood, then of course you've got to bronchoscope them. Weight loss and so on. Always think about ACE inhibitors. Something like 10% of the patients referred to our clinic still on ACE inhibitors. It takes 90% of cough goes away within a fortnight if you stop an ACE inhibitor, but the other 10% takes about 3 months, so you have to be patient. So these are the red flags: foreign body, anybody choked, hemoptysis, weight loss, urgent bronchoscopy for all those. This is a rice ball that we found at bronchoscopy without any obvious thing on the x-ray, but caused a severe cough, aspiration, benefit. So we investigate and treat the common triggers, and I think of these conditions not as causal, but as triggers. Why do I think that? Well, if you go to the reflux clinic or the asthma clinic or the postnasal drip clinic, there's nobody coughing. So those conditions can't be the sole cause. So what we believe is that this is primarily a neurological disorder, a neuronal disorder. Jackie hates it. I call it neuralgia, but it's the same as effectively as a neuralgia, like a post-herpetic neuralgia, but occurring up here. Nerves become permanently hyperresponsive, and then these conditions can act as triggers in a hyperresponsive airway. So the patients, if you ask them, say, I feel crackles. Sometimes they say they've got phlegm that's choking. So that's a slightly different one. But most patients say they've got a sensation of itch. 85% say it's about there. 10% say it's somewhere in their chest. Probably means this is heterogeneous, because it means probably the triggers and the signals to drive it are different. But you get this gentle tickle and it becomes an irritant. It increases and increases till they have to cough. So the idea is that noxious sensations, congestion, irritation, produce this urge to cough and make you cough. So what about asthma? Can it act as a trigger? And of course it can. Of course, in classical asthma, people have cough. They do have cough as part of their condition. They have asthma symptoms, they wheeze, they have the usual measures of inflammation and hyperresponsiveness. But there is a condition called cough variant asthma for sure, where asthma symptoms in terms of wheezing are minimal, but they have, in other words, they have very mild asthma, but they still have the positive features in terms of inflammation and histamine challenge. And then there's this unusual condition called eosinophilic bronchitis, in which they don't have symptoms, they don't have the histamine hyperreactivity, but they have eosinophilic airway inflammation. Important to know, and this is a biopsy diagnosis at bronchoscopy, because they're responsive to oral corticosteroids. So if you think somebody has background asthma, these are the investigations and the routine treatment trials that you would give to anyone who had asthma. We're often left, though, with asthma that's completely controlled, and still patients have a cough. It may be better. It doesn't usually disappear. Postnasal drip, I think, is an interesting idea, and I think we're getting more understanding of that now. It can be, of course, postnasal drip can make people cough. a number of causes. We do investigate patients a lot. I would have to say that the treatment of nasal disease rarely impacts cough. They get sent to ENT surgeons. ENT surgeons operate on them because that's what they do. You go and see the plumber, they'll plumb you. But rarely does it make a difference to cough. There is probably a truth in the fact that people with cough hyperresponsiveness have an abnormality of airway nerves that can extend up into the nasopharynx. And so the sensation, I stand in front of you, can hear me now with postnasal drip all the time. I've got sinus disease, I never cough. But if I had an abnormal sensation, then I would cough. I think that's the difference between me and those patients. So reflux is the really difficult issue, and it's been, I think, misunderstood. So the thing about reflux, of course, is that the vagus nerve takes the innervation from the esophagus as well as the airways up into the same area. The question is, why would reflux drive cough? Is it reflux all the way up and microaspiration? Or is it some neuronal crosstalk in a sensitized system? And it's quite clear to me that it's the latter. Why do I say that? Well, if you take chronic cough patients here, compare them to healthy volunteers, what you find is that for all reflux events, acid reflux, non-acid reflux, or proximal reflux, which is the thing you're really interested in, there's actually no difference between patients with chronic cough and healthy volunteers. They don't have more reflux. But if you put down an esophageal manometry probe and you put a cough monitor on, so you're making simultaneous measurements, there is a time relationship between a reflux event and cough. So if you reflux into your lower gullet, in a half of patients, they will cough within the next 30 seconds. It's not because it's coming all the way up and down and making them cough. It's simply because it's probably sensing and triggering a sensitized vagal pathway. So this neuronal crosstalk is why we think this happens. Why is that important? So these are the tests we still do. I have to say that we still give twice daily PPI and nocturnal H2 antagonists to try to control reflux in this circumstance. And I think what we're trying to do is suppress reflux into the distal esophagus. But rarely is it successful unless patients have truly symptomatic reflux. So all the trials of PPIs in chronic cough are negative. Except if you mine down to those patients who say, yes, I've got tremendous heartburn, then there's some hint that those patients improve with a PPI. And then we go, so that's reflux, and now we're going on to investigate and treat rarer diseases. You, of course, in the difficult patients, you're really down to rarer stuff. So HRCT thorax to look for pulmonary fibrosis. You're doing nasendoscopy, you're bronchoscoping, you're doing complex measurements. And you should refer to a specialist clinic. Why do I think these patients, what do I think the primary disorder is here? You're going to give me a timing, Peter, if I'm going over?
A little left.
5 minutes?
5 minutes, 5 minutes, yeah.
Okay.
5 minutes. For you, 5 minutes.
Thank you so much. So there you go. If anybody's ever done cough studies, they'll know that what people generally do is something called the C5. They get people to inhale capsaicin until they cough 5 times. And that's been generally the differentiating thing. Now look, this is 5 down here, right? What you can see is that the C5 does not differentiate between volunteers, chronic cough, asthmatics, and COPD. There's a lot of overlap. So this is a typical dose-response curve, and here we've done full dose-response curves. We've driven right up the capsaicin dose, log dose here, and measured the number of coughs. This is a lot of coughs to be triggered. All right? It's unpleasant. But what you find is that, in fact, of course, a dose-response curve has a slope and then a max, doesn't it? And the difference here is that slope is shifted to the left in patients with chronic cough, but there is overlap. The problem is these patients have hyper-responsiveness, not hypersensitivity. So that's the difference is up here, not so much here. There is some here. So these patients, you can see all the error bars are different. And patients with asthma and COPD are intermediate, but still separated from normals. So this is a disorder of cough reflex hyperresponsiveness, primarily. So you have all those things there, but actually your problem's that. You see that? Got all those things. They're triggers, but actually chronic cough patients have that disorder. These are patients with refractory, difficult to treat cough, and they're really common and quite distressed. What do we do about it? There are no licensed treatments. Low-dose morphine, 5 milligrams twice daily, helps some patients. This is cough score here. It hasn't been done objectively yet. It will be soon. Placebo against 5 milligrams of morphine. The eagle-eyed of you will realize some patients do miraculously on low-dose morphine. They don't get tachyphylaxis. The effect doesn't wear off. They get constipated, I think, is really the only thing that happens to them. Some people have very little response at all. The data we have is that about 50% of patients have a clinical response, 50% have none at all, and I cannot pick them at the moment. There must be some way to work out which. Gabapentin is recommended following an Australian trial. In our hands, it helps a third of patients and makes everybody else fall asleep. So generally, it's hard to handle as a drug. Don't like it. Pregabalin's maybe a bit better, but still. Speech and language therapy, again, an Australian study from Anne Vertigan, published now a decade ago. Really hard to replicate these studies, but they had to do sham speech and language therapy. So it's a proper controlled trial. And what you can see is in cough here that pre and post SLT, there's an improvement, but not on pre and post sham, or less on pre and post sham. It does not cure these people, but in some patients, it does give them a measure of control. And this is the big news. Last year, Jackie's group studied this drug, a P2X3 antagonist. It's a completely left field drug. It was in use for pain. And they came and asked us, do you think it might work in cough? And we said, no idea. Turns out it's on C fibers, and this drug, AF219, completely stops people coughing. About 75% of patients get a 75% improvement in cough, which is like something we've never seen before compared to placebo. The only problem is it takes your sense of taste away completely. So this was a dose of 600 milligrams, which is the maximum tolerated, and we now have data showing that 30 to 60 milligrams is the right dose range. We overdose by a factor of 10. The taste improves at that point. So this is a disorder of neuronal dysfunction. Airway ATP is important, we think, in this. I'm not going to go into that today, in stimulating the vagus, which causes the hyperresponsiveness, and you can block this with appropriate molecules. Conclusions: cough is common. It's very impactful for patients. It's been called the cough hypersensitivity, but it's really a cough hyperresponsive disease. Diagnosis and management can be troublesome and difficult. You've got to get good at this. The options are limited. Multiple neuronal targets are coming, and I've just given you one example, but other drugs, NK1, will almost certainly come to the market in the next couple of years. And we're making great progress, and thank you very much.
Thank you very much indeed, Ashley. Joking aside, that was a tour de force, a fantastic summary that shows why understanding what goes on can translate into simple and relevant clinical medicine. Are there any questions from the audience? Ashley has to dash shortly, so we've probably only got time for one. Thank you. Could you go up to the microphone, please?
I'm sorry I
Because
ran
we're
over a little,
recording
by
this.
the way. Apologies.
Not to worry.
Lot to say.
Thank you for an excellent speech. I have a small question. Do you think there is any role for first-generation antihistamines in controlling chronic cough?
I think there has been. We get to desperate by the time we get through the first batch of...
It's mostly sedative, probably.
Yeah, that's right. They probably sleep better. There's evidence for amitriptyline, 10 milligrams at night. It's probably because it makes them sleep better. And, sleep disturbance is a real problem for these patients.
Their wives bring them, actually.
Yeah. That's right.
They both can sleep.
Yeah. So I think what's two things about this. First of all, we've completely miscued by calling this a disease of those other diseases, a manifestation, where actually we should have been looking neuronally 20 years ago. And the patients have been... It's a curious thing because actually it's a disease in its own right, and it's not really in the textbooks as such. So it's interesting from that perspective alone. Thank you.
Thank you very much, Ashley. It's my pleasure now to call for Peter. Peter Carl is one of the global experts on COPD and will update us on COPD management 2016.
Thank you very much indeed, GB. I mean, it's hard to follow that because that's such an elegant and relevant presentation. What I'm going to talk about, however, I think is nonetheless important, which is managing COPD in 2016. And this is going to be literally a whistle-stop tour because, like Ashley, there's far too much to say that's relevant and important. I have worked with a variety of pharmaceutical companies, but never with tobacco companies for obvious reasons. It's clear that COPD is still a really important disease. This is a conference which is predominantly about tuberculosis. And if you look down here, you see that back in 1990, the Global Burden of Disease study thought that tuberculosis was the 6th commonest cause of death in the world. But they are hoping that it's going to go down thanks to the efforts of organizations like the IUATLD. By contrast, COPD was the 4th commonest cause of death, and it is increasing its role. And that is not just because of COPD in developed, well-established economies. It's very much the impact of COPD occurring in poorer countries and in countries with rapidly developing economies. So it's a very relevant and pertinent challenge. And because I'm not going to say it anywhere else, I need to say it here, COPD and tuberculosis are linked, just as they're linked through smoking. And that is something that people sometimes forget. So I think it's not inappropriate to discuss this at a meeting like this one. We've learned a lot recently about the natural history of COPD. The classic idea was that people who were exposed to something like tobacco smoke would show an accelerated loss of lung function over time compared with people who were resistant to tobacco smoke or who had never smoked. And that is still true, as this composite paper from a variety of people, including our mutual colleague Jeroen Vespo, showed nicely last year. But the other thing that they also showed was that about half the people in this large, predominantly Western study had not reached their expected or anticipated lung growth by the time they were in their 20s. And they had a somewhat, if they declined, they didn't need to decline as rapidly to get to the same point that these people did. So these are the people with a rapid decline. These are the people with a modest increase in rate of decline of lung function. And the real problem was what happened in early life. Now, why is this relevant in this context? Well, if you actually look at data, such as this data from Mexico, from Raul Sansores and colleagues, you see that where they followed a large group of smokers up over a 15-year period, they had an accelerated loss of lung function, just what you expect. These people were exposed to biomass, which is the other global major cause of COPD. They started off at a lower lung function, although they had similar age and sex distribution, and their rate of decline was slower. And the point I'm trying to make here is the same kind of point Ashley was trying to make about cough, that actually our understanding of this is not necessarily relevant. It's not necessarily correct. We cannot take all the data that comes from a group of people that's generated where the COPD has due to tobacco smoke and necessarily apply that to people whose COPD is being driven by other causes, although there are, of course, plenty of people who have both factors leading to their problem. So the first issue in management, if you're thinking in a global sense, is to decide what are the key factors that are driving this disease. Now, the global strategy for diagnosis and management of COPD, commonly called GOLD, is something that I was involved in setting up remarkably 15 or more years ago now. And its treatment recommendations have been widely taken up and indeed are just about to be revised in a couple of weeks' time. I'm fairly confident that they're not going to say anything different about the non-pharmacological management. They're going to emphasize smoking cessation. They're going to emphasize the importance of pulmonary rehabilitation in symptomatic people. They're going to say it's a very good thing for people to undertake physical activity, a particular issue in more developed economies, and that standard vaccination programs, particularly for influenza, but probably for pneumococcal vaccine, are relevant in terms of preventing complications in COPD patients. It's worth noting that the WHO, in revising its advice in something called Appendix 3 of their non-communicable disease document, is now emphasising the need for cleaner air, better ventilation in the home and cooking stoves. And I know earlier this week my colleague Kevin Mortimer has been talking in this meeting about the importance of cooking stoves in his studies in Africa. And I think we're going to get more information about this over in the coming years. So there are some really important public health things that can be done in the context of COPD management. But for a lot of people, what they think about is something like this diagram, which is the GOLD version of pharmacological therapy. And certainly pharmacological therapy is an important part of COPD management. And broadly, as people get more symptomatic and or develop more risk of exacerbating, so the intensity of drug treatment has increased, and the recommendations have largely been that as therapies increase in intensity, you should think about inhaled steroids and long-acting beta agonists more. Now, some of this classification will be revised, should I say, in the document that's coming out in Philadelphia in 2 weeks' time, or at least going to be presented. And the exact details of that we'll have to see, because it was still being finalised a week ago, as far as I know. But undoubtedly, the general emphasis on using symptoms and risk of complications like exacerbation will be retained. So what can we say that's relevant about drug treatment? Well, probably this is the most relevant slide I'm going to show you. It's a comparison of the risk of exacerbations in people who are taking tiotropium, a long-acting antimuscarinic drug taken by inhalation, compared with indacaterol, a very good long-acting inhaled beta agonist. Both drugs are given once daily, so there's no issues about the timing of it. And you can see that there were significantly fewer events in the people who took the antimuscarinic drug than the people who took the long-acting beta agonist. So if you can afford it, or to be more relevant, if your patients can afford it, and they can use one drug only to really help their symptoms of COPD, their chronic breathlessness, their frequent exacerbations, their generally feeling unwell, then a long-acting antimuscarinic drug by inhalation would be the best value, and it would be more effective than the short-acting drugs, which are the default mode recommended by WHO. Drugs like tiotropium are coming off patent soon, and that should reduce the cost to the consumer. And that remains, I think, a very viable basic treatment for people to manage their symptoms, along with other general health measures like exercise and smoking cessation. But there are other things that have been happening, particularly because of what's been happening in the developed world economies. For instance, we've looked at new long-acting beta agonists and inhaled steroids. And by the by, I do think inhaled steroids have a role in people who have COPD and a past history of asthma. There's another group I'll come to in a moment. This is a study which we published in Lancet Respiratory Medicine 2 or 3 years ago, but it's representative of what happens with all of these. The comparator group here, we're taking Vilantrol, a long-acting inhaled beta agonist. These are people who took the LABA and the ICS together. This was fluticasone fumarate, the inhaled steroid. The higher the dose of inhaled steroid, the better the prevention of exacerbations. That's very much in line with what we've seen with LABA ICS drugs previously. It was a particularly nicely done demonstration of it. But unfortunately, it was also a nicely done demonstration of the fact that whatever dose of this inhaled steroid you took, you doubled the rate of radiologically confirmed pneumonia. And that has caused people to be concerned. I am less concerned, and particularly in the context of developed economies, that this is such a big issue, but it is a fact, and it is a particular issue for drugs of this pharmacological grouping. People have therefore looked at other ways of improving existing treatment, and unsurprisingly, they've tried to combine LABA and LAMA, long-acting inhaled drugs with low side effect profiles, together. This is one of those sort of combinations. It's a combination of tiotropium and olodaterol. It's a dose-ranging study. It goes over a year, and you don't have to be a genius to say that giving 2 bronchodilators produces a bigger FEV response than giving 1 bronchodilator. These are big studies, 5,000 people, 1-year follow-up. Health status improved a little bit, not massively, but a little bit, in the people on the 2 bronchodilators rather than 1. So probably there's some gain for some people in there, compared with this really quite effective drug, which was the LAMA on its own. Then we come to the question of, well, okay, you've got LABA-ICS and you've got LABA-LAMA combinations. Which should you use? And until recently, I think most of us would have said LABA-ICS. But then this paper from my friend Vishy Vidzika came out in the summer that showed that the chances of exacerbating were lower if you're on a LABA-LAMA combination, 2 inhaled bronchodilators, than on a LABA-ICS combination. And that was true for all exacerbations, moderate to severe exacerbations, and even of those needing hospitalization. So it does look, and there are other data that support this, as if dual bronchodilators is at least better than using LABA-ICS in terms of preventing exacerbations. And of course, there's no excess pneumonia risk. Therefore, we should think about, do we need to give inhaled steroids to a lot of people taking them with COPD? It is certainly worth considering from a cost point of view, but remember the data I've shown you apply to LABA-LAMA combinations, and they also are not cheap. Certainly, patients may be worried about it. I think if patients have had pneumonia previously, you ought to review your treatment option. You should consider local side effects. Drat, it's the wrong slide. The slide that was supposed to come up was to say, what about previous tuberculosis? Previous untreated TB is associated with an increased rate of reactivation if you give people an inhaled steroid for their COPD. Not enormous, but a very definite and measurable fact. Again, relevant to this meeting. And so in this context, I think you really should pause for a moment and think, is inhaled steroid needed? It doesn't mean it isn't. We did test the hypothesis in people who had quite severe COPD and exacerbations to see whether or not you could safely withdraw inhaled steroids if you gave them if they continued to take a LABA-LAMA combination. And in fact, that's the exacerbation rate of people who use LABA-ICS and a LAMA. And the orange line is the rate of people who just use the 2 bronchodilators alone, and there's no difference between them. So we've swung somewhat over the last 5 years from recommending LABA-ICS combinations as the standard drug treatment for COPD, away from that and emphasizing bronchodilators more. Whoops, let's go back to that one. There is, however, this analysis. Remember I showed you those data about the bronchodilator and the bronchodilator inhaled steroids? When those data were analysed by blood eosinophil levels, it turned out that people with high normal blood eosinophils got much more benefit from taking an inhaled steroid than they did from just taking a long-acting beta agonist alone, at least in terms of exacerbation prevention. And we looked in our wisdom data, the paper I showed you a moment or two ago, and found in the smallest subset of people with generally rather high blood eosinophil counts, or at least very high normal values of above 400, that there was a clear benefit there was clearly a risk of relapse if you stop the inhaled steroid. So there's probably a small core of people who really do benefit from having an inhaled steroid as part of their treatment regime. But for most people with COPD, particularly Western-style COPD, they can get by with adequate, effective inhaled bronchodilators. What other drugs can we offer? Well, N-acetylcysteine is an example of a so-called mucolytic or antioxidant group of drugs, and it's much cheaper than the things I've been talking about. And it's very widely used, particularly in Central Europe and parts of Asia. Does it work in COPD? Well, these data from Zheng and colleagues suggest that it does work in people with moderate COPD in terms of preventing exacerbations. It doesn't affect symptoms. That's the downside of it. But it does prevent exacerbations, and largely those are exacerbations that do not need treatment with antibiotics or steroids. So it has some impact, but it's not going to stop the really troublesome events that worry patients most. You can do that if you give people long-term azithromycin, as this US study showed, a significant reduction in exacerbation risk compared with placebo in this big trial. However, there were still issues about this study. It didn't work, this treatment didn't work in people who continued to smoke, and there were some geographic factors that needed explanation. Didn't seem to work in hot and humid environments. But the real worry is if you start giving everybody with COPD lifelong oral antibiotics, and this was azithromycin daily for the year of the study, then you're going to develop antibiotic resistance. This is a racing certainty, and this meeting above all understands that concept. So it's very interesting. It's probably relevant for a selected few patients, but I would hate to see this adopted as the standard of care for COPD worldwide. There are other treatments which are not pharmacological. We're going to hear something about NIV subsequently from Rob Parker. But there's been a whole host of treatments, largely focusing on those people who have severe emphysema. This is one of them. It's a coil you can put into the airway, which promotes airway collapse. There are a variety of valves and other surgical treatments. All of this can be done bronchoscopically rather than involving open surgery. This particular trial that was published this year in JAMA showed improvements over the course of its 12-month follow-up, an improvement in walking distance and lung volumes, and a big change in health status. So that was really very encouraging. It's one of the most encouraging medical lung volume reduction trials. But this is still treatment that is in progress, and there are still complications, and it's still decidedly a subset of people in specialist centres with experienced operators where you should think about this form of intervention. Perhaps the last and most important thing I've got to tell you is that these people exacerbate. And when they're treated, there is benefit in giving them a short course of oral corticosteroids. And these data show that if you gave 5 days of 40 milligrams of prednisolone compared with a more conventional 2 weeks, you didn't make any difference in the rate of relapse. And I think we should not be poisoning our people with extended courses of oral steroids every time they exacerbate. Oral steroids are cheap, and people sometimes feel better, but there's no benefit for going beyond 5 days in the treatment of an exacerbation of COPD. And in terms of well-being, if you remember nothing else I've told you, remember that. So, what do I think? Oh dear. COPD is not the same everywhere in the world, and I think our treatment should begin to reflect this. Long-acting antimuscarinic drugs are the best, most cost-effective option for COPD management, if you can afford even them. LABA and inhaled steroids work, but really you should keep them for people where you thought they had asthma in the past, or perhaps, if you've got the information, if they have a high normal blood eosinophil count. There are other options that are help that I've talked about, but general health measures are the key. And I've not had time to say anything about the bronchiectasis COPD overlap syndrome, which in large parts of the world is also a real entity and a very difficult management problem. So what I'm trying to say is that COPD is a global health problem and it needs global health solutions. It hasn't gone away, and we've got to do what we can, because like tuberculosis, it is a preventable disease. Thank you.
Thank you very much. Is there any question for Peter? Otherwise, I have one myself. Having also public health in mind, so in your opinion, which are the first 3 priorities to fight COPD as a kind of global perspective for the future?
Very big question, important topic. The 2 things that I would instantly say, well, there are 3, of course, not 2. And they're well known to us. We've got to work together. Everybody, all doctors, all patients, in all circumstances, to reduce the use and discourage the uptake of tobacco. I still remain anxious about e-cigarettes as an occult way of getting more people hooked on nicotine and going back to tobacco through a backdoor route, but I'm a paranoid guy. But that has to be still the #1 goal. But it has to be tackled with a demand that people have a human right to clean air. Clean air indoors and outdoors, air that does not damage them, air that nourishes them. And I think that has to be a huge focus. And the last, and again, something that echoes time and again through this meeting, it's poverty and addressing particularly child nutrition. I think COPD really is a disease that begins in a pediatric sense. It begins with undernourished children, and particularly poor children as they get older who start to take up smoking. So there's public health issues. Those are things that we have to focus on. It's not rocket science, but goodness me, people need to be reminded of it.
Thank you very much. Yes, I go with him. Yeah, I go with him. Okay, it's my pleasure now to introduce Mark Gaudat from the Department of Respiratory Medicine of the University of Manchester, who is, let's say, the father of the infection assembly in the ERS, among other things. So he's the person that in the ERS has contributed most to create a special study area for infections. And he will present us the status of the art on pneumonia. Mark.
GB and Peter, thank you very much. It's a great pleasure to be able to speak at this important conference today about pneumonia, which, as you will have seen from one of Peter's slides, under the respiratory tract infection heading, was either 3rd or 4th in the list of causes of death worldwide. Inevitably, in the short time available, I've had to pick and choose a few things to talk about today because the topic's quite big. I don't have any conflicts to disclose apart from one right at the end, which I'll explain it when I get there. So in this short talk today, I'm going to try and talk a little about severity assessment in community-acquired pneumonia, pathogen detection, quite a bit about antibiotics, because that's usually what people are mostly interested in, a bit about steroids, and then I will end briefly talking about hospital-acquired and ventilator-associated pneumonia. Severity assessment. This is the way we used to do it, and this is the way that we still do it. Careful physicianly observation of the ill patient. We know from various studies that this is a reasonable approach, but we can do it better if we add to this some objective severity assessment tools. And there are a number of these around. Using these tools helps us to determine where we're going to manage the patient, at home or in hospital or the intensive care unit, how vigorously we're going to investigate them. It helps us deciding antibiotics, and it also gives a prognosis to the patient and other members of the family, knowing how severely ill they are. The various guidelines perhaps are a little bit confusing because they tell us to use different scores. So the ATS-IDSA guidelines suggest that either the CURB 65 score or the pneumonia severity index can be used. The ERS ESCMID guidelines suggest the CRB65 score, the NICE UK guidelines, CRB65, but also talk about the CURB 65 score. So that gets a bit muddly. So which ones should we be using and why? What they all do, all three of these scores, CURB 65, CRB 65, and the ATS-IDSA scores, help us to separate three groups of individuals with pneumonia, community-acquired pneumonia. Those who have a very low risk of death, 1% or so, those who have a significantly high risk of death of about 1 in 5, and those in an intermediate group. So all of the scores do this. Which one should we use and why? Well, complexity is an issue. The Pneumonia Severity Index is a 20-variable score with different weightings for the different variables. So unless you've got an electronic patient record that automatically calculates this, I would suggest it's not practical. The two simple scores are the CRB65 score, where you just count up how many of 4 variables are present, and the CURB65, which has 5 variables with urea added in. Now this makes it a little bit more complicated because you've got to do a blood test, so it's probably only practical in hospital. But even in hospital, should you use CURB65 or should you use the simpler CRB65? They're both easy to do. Well, the main difference between these two tests is how it apportions patients into the risk groups. So if you compare CRB65 with CURB65, CURB65 gives you very many fewer patients in this intermediate group. And its biggest effect is increasing the size of the low-risk group. So economically, this is important, and socially this is important, because it helps you to allow a bigger proportion of your patients to be managed at home. It also picks out a slightly bigger high-severity group. So our health managers would prefer us to use CURB65, and logically that's the best score to do if you can measure the blood urea, because it allows a bigger proportion of patients to be allowed home. Detecting pathogens, something that we all do, but we're all very bad at. It's important because there are many different microbial causes of community-acquired pneumonia, and the antibiotics that we use should be directed at the cause in an individual patient. But the conventional microbiological tests that we use, culture and sensitivity testing, are slow and they're pretty insensitive. But we now have available, increasingly, these newer molecular biological tests, PCR-based tests, for detecting pathogen genomes to assess their presence. Does this help us? Well, this is a nice study from a Scottish group which looked at a reasonably large number of adults with community-acquired pneumonia. The majority were older people, which is the sort of population that we see, and it had the sort of outcome that we see in routine hospitals. So this was a typical population of patients with community-acquired pneumonia seen in hospital. Sputum samples were obtained from nearly every patient, and in a small number endotracheal aspirates. And they compared conventional culture with a reverse transcriptase PCR test, multiplex test, which looked for 26 different bacterial and viral pathogens. And they found that using conventional bacteriology, they were able to find a bacterial cause in 39% of patients, but if they used the PCR-based technology, this increased dramatically to 81%. So you can dramatically increase your pathogen detection by using these new molecular biological methods. Adding in the virus test didn't add very much, and that's because in adults, at least, viruses are probably not that important, and we don't usually have treatments for them anyway. This figure of 39% is what they found in the study. It's way higher than what we actually find in routine practice. In routine practice, the way we use these tests, we probably come up with a figure of about 10%. But nevertheless, the principle is the same. We have a much greater capacity to detect pathogens if we use these molecular biological methods. And what these authors predicted from their tests, the biggest clinical effect of using these tests potentially would be to de-escalate antibiotic use in 3/4 of patients, because we overuse antibiotics. We try and give more antibiotics than we should do, and using these tests had the potential to reduce antibiotic exposure in our patients, which is important for antibiotic stewardship. In a small proportion, it would have led to escalation in antibiotics, and in another smallish proportion, no change in antibiotics. So it has the potential to translate into an important change in practice. The problem is we don't actually know whether it will work in practice. We as clinicians are very resistant to change. So studies need to be done to see if in routine practice this will make a difference. And of course the cost might be an issue because these new tests are more expensive than the older conventional culture tests. But there's certainly potential there. Moving on to antibiotics now, talking a little bit about how quickly we should give antibiotics. It's common sense to think that we should give antibiotics early to our patients with pneumonia. The evidence base for telling us that this alters outcomes is relatively poor, and that's because we can't do high-quality trials. You can't ethically delay antibiotics in a group of patients to see if giving antibiotics at different times makes a difference. So we have to rely on retrospective cohort studies. And much of the data that we have is based on a single US study, a very large US retrospective study in the over 65s. Well, we've recently, last year, published a large cohort study from the UK, where we looked at nearly 14,000 adults managed in British hospitals, in 188 different hospitals in the UK, looking at adults admitted to hospital in the winter months over a 4-year period. Again, these were typical adults admitted to hospital with pneumonia. And what we found was that with every 4-hour delay in antibiotics being received by the patients resulted in an incremental increase in mortality. So giving antibiotics early does appear to be associated with a better outcome. Giving your first antibiotic within 4 hours of presentation to hospital was associated with a 16% reduction in adjusted mortality. Now, of course, because this is retrospective, it doesn't tell us that giving the antibiotics earlier was actually the cause of the reduced mortality. It was just an association. So we don't know whether it's the antibiotic effect or whether this is just a marker for better overall care. But nevertheless, it supports the recommendation that antibiotics should be given to our pneumonia patients as soon as we suspect the diagnosis, and that should result in better outcomes. Which antibiotics should we give? There's a wide choice of different antibiotics. There's always and still is a debate about how important the atypical bacteria should be. These are not usually sensitive to beta-lactams, sensitive to macrolides only. Should patients always get a macrolide? Do we use a beta-lactam alone? Do we use a beta-lactam with a macrolide? And again, we have lacked good quality studies in this area. And so the guidelines give us slightly different advice. So the ATS-IDSA guidelines suggest that a combination of these two should be given for all patients admitted to hospital, regardless of illness severity, whereas the European guidelines suggest that illness severity is important, and if they're not severely ill, a beta-lactam alone is adequate. But if they are severely ill, two together. Until recently, there have been no randomized controlled trials to test these two interventions, but there's a very nice Dutch study published at the end of 2015, which looked at a large number of adults and compared beta-lactam alone with beta-lactam plus a macrolide versus a fluoroquinolone, and using mortality as an endpoint. Large number of patients, nearly 1,000 patients in each arm. Overall, low mortality, but this study was powered based on that mortality. And they found overall that there was no difference. There was no difference in mortality whether you used a beta-lactam alone, a beta-lactam plus a macrolide, or a fluoroquinolone. If the confidence intervals fitted into this shaded box here, then that meant there was no difference. And not only was there no difference in 30-day mortality, there was no difference in 90-day mortality, no difference in length of stay, and no difference in complications. So this is the first good evidence that we've got that in these relatively non-severely ill patients, giving a beta-lactam alone is probably adequate and is safe. There was a meta-analysis published in JAMA this year of all of the antibiotic studies comparing beta-lactam alone with either a fluoroquinolone or a beta-lactam plus macrolide. All of the confidence intervals are situated around the unity line. The majority of these studies are retrospective cohort studies and are therefore biased by intention, and therefore this isn't good quality data. And these circled boxes are the confidence intervals from the study that I've just shown you, showing that they fit very much either side of, or across the unity line. So for non-severely ill patients, it appears that a beta-lactalome is probably okay. So most of the data in the meta-analysis was biased by intention. The studies did vary an awful lot. Some had a mortality as high as 23%, and none of these studies adequately assessed the potential harms of giving 2 antibiotics versus a single antibiotic. 2 antibiotics, twice the harms, single antibiotic, so 2 is probably worse. So I think we can conclude that for non-severely ill patients, a beta-lactam alone is probably safe and effective. We still have no good studies in severely ill patients to tell us what's the right antibiotics to use, so common sense suggests beta-lactam plus macrolide is the right thing to do. So severity assessment helps us with a guide to which antibiotic to give. How long should we give antibiotics for once we've started them? Another vexed question. A recent randomized clinical trial from a Spanish group. They looked at patients with community-acquired pneumonia. They gave everybody 5 days of antibiotics, and then they randomized individuals at day 5 into either doing whatever the physician wanted to do, or if the temperature was down and they had no signs of clinical instability, stopping the antibiotics. And they found that in the intervention group, the duration of antibiotic treatment was significantly less than in those that wasn't the intervention, and the outcomes were exactly the same, that it was safe to stop antibiotics at 5 days. This supports a meta-analysis which we published in the UK NICE guidelines of earlier studies which showed that shorter duration antibiotic treatment was at least equivalent to longer duration antibiotic treatment, possibly even better. So for non-severely ill patients, 5 days of antibiotics is adequate. You don't need to treat for longer than that. For severely ill patients, we have no studies. We don't know. Most guidelines suggest 7 to 10 days, and that's a reasonable option, but it's not based on very hard evidence. Briefly, corticosteroids in pneumonia. Corticosteroids are not a current standard of care, but it's something that we tend to go to when everything else is failing. And there is a priori idea that steroids might help in infectious diseases. It is a standard of care for patients now with bacterial meningitis, and there is one pneumonia, pneumocystis, where there is a hard evidence base that shows that adding steroids helps outcome. In community-acquired pneumonia, we don't know. There is a small amount of evidence in some fairly poor studies in severe pneumonia, but there's been a flurry of two new studies and a flurry of systematic reviews. A flurry of systematic reviews is usually a bad sign in my book because it suggests that people don't really know. And I think that's what the systematic reviews probably tell us. So there's a number of editorials. This one in The Lancet said, steroids for pneumonia, it's not yet time. This one, which I think was in Clinical Infectious Diseases, said steroids for pneumonia, it's time to change practice. And in another one, and I can't remember which journal this was in, sit on the fence, cautious optimism or wishful thinking. And this is because the systematic reviews come to different conclusions. This one said it lowers the mortality. This one says it lowers the mortality by 3%. This one said the effect on mortality is uncertain, and this one didn't make any comment on mortality whatsoever. So the data is still confused about steroids in community-acquired pneumonia. The reason is because the studies that have been included in these systematic reviews are different. The studies use different drugs, different doses, different durations, and they've used a variety of different endpoints. So it's a muddle. It's possibly a little bit clearer in influenza, another area where we have a lot of interest as to whether adding steroids would be helpful. A single systematic review, this time published on the Cochrane database, predominantly of patients who had H1N1 in 2009. And they found in this meta-analysis fairly categorically that those who received no steroid did better. So giving steroids was harmful. Now, again, a caveat to this is that in the majority of cases, or virtually all cases, this is retrospective, and so there may be bias by intention to treat, and it may be that sicker patients were given the steroids. But at the moment, the recommendation for influenza, the finding in influenza is that steroids increase mortality and increase the risk of hospital-acquired infection as well. So there's no support for the use of steroids in pneumonia or influenza at the moment. There is a nagging question about whether there might be a subgroup where steroids would help, but certainly not in the majority. Finally, hospital-acquired pneumonia and ventilator-associated pneumonia. Very helpfully, ATS-IDSA published new guidelines for hospital-acquired pneumonia just a couple of months ago in Clinical Infectious Diseases. Big document, awful lot to go through, so I'm only going to give you the headlines. And perhaps the most important headline is that the concept of healthcare-associated pneumonia, which was introduced in the last ATS-IDSA guidelines, has been booted into touch. It is not a helpful concept. The idea was that healthcare-associated pneumonia, which was patients who'd been in hospital in the last month, patients from nursing homes, patients on IV immunoglobulins, patients on hemodialysis, all grouped together, had an increased risk of multi-drug-resistant bacteria. Studies have shown that they do not have an increased risk of multi-drug-resistant bacteria, so using this concept of healthcare-associated pneumonia is now gone. Very good guideline, formal evidence base using grade criteria. The main findings are getting rid of HCAP, as I've said. The second very important finding is that if you're treating a patient with hospital-acquired pneumonia, you need to know what the pattern of bugs is in your hospital. The most important causes are going to be gram-negative organisms, possibly staph, possibly MRSA, but you take two hospitals a mile apart, they may have the same bugs, but they will have different sensitivity profiles. So you need to know what the antibiogram is in your hospital and treat accordingly. Procalcitonin may be a useful biomarker for helping you to know when to stop antibiotics in patients with HAP or VAP, but it's not particularly helpful for knowing when to start. And empirical duration for treatment, slightly longer than for CAP, is suggested to be 7 days. So those are the main new things that are in the guidelines. One other new thing to mention finally is this new concept of walking pneumonia. Those of you who have been following the US presidential election will be very familiar with this. It's one of the few things in the election campaign that we can't actually blame Donald Trump for, I think. But I think it's probably something that probably isn't going to rear its head again, so you don't probably need to know too much about that. And I think on that rather gentle note, I'll stop. Oh, one final thing. These are the UK NICE guidelines for community-acquired pneumonia and hospital-acquired pneumonia, probably the best evidence-based guidelines for CAP, and I would recommend you have a look at those. And I do have a conflict of interest because I was the coordinator of these guidelines. Thank you very much.
Thank you very much, Mark. Thank you for a brilliant presentation. Any question for Mark? Very good. Excellent. In the microphone. Please introduce yourself.
Hi, thanks very much. Steve Aston from Liverpool. I wondered what your opinion was about the choice of the beta-lactam backbone in treating severe CAP. There are some local hospitals that choose just to use a narrow-spectrum IV penicillin rather than a broader-spectrum cephalosporin or with a beta-lactamase inhibitor. Do you think, and that's from a stewardship point of view, do you think that's safe, or would you recommend otherwise?
Well, the honest answer is I don't know. There is no evidence on which, or hard evidence on which, to give a clear answer to that or a clear recommendation. If you were admitted to hospital with severe pneumonia in Norway or Sweden, you would be given IV benzyl penicillin, and if you're severely ill, you might get a macrolide as well. They wouldn't use something like coamoxiclav. And as far as we know, their outcomes for severe pneumonia are no different to elsewhere in the world. Swings and roundabouts in the UK, some hospitals recommend coamoxiclav, some recommend amoxicillin, some recommend benzyl penicillin. The antibiotic stewardship issue is more about how you use your antibiotic rather than the actual antibiotic that you use, I think. And as long as you are careful in using those for just the severely ill and not everybody who comes in with cough. Ashley Woodcock didn't mention antibiotics, I'm was pleased to hear. Then you don't have a stewardship problem. But whether you get a better outcome with one or the other, we have no evidence.
Thank you very much indeed, Mark. That was a terrific talk. We're going to move on for our last speaker to somebody who, like me, is local. Robert Parker works at University Hospital Aintree, has a particular interest in ventilatory support, acute and chronic, and is going to take us into an area which has been in the doldrums for a while, but which has begun to change, and which still has relevance for that subset of people with substantial ventilatory limitation, specifically domiciliary non-invasive ventilation for COPD. Robert.
Thank you very much. So, as Peter says, I work locally, involved in a long-term ventilation service with colleagues for both invasive and non-invasive ventilation. Housekeeping, I have absolutely no conflicts of interest to declare in this or any other matter, and all views expressed are my own and not reflective of either the ERS or my employer. Beg a bit of indulgence. When I was asked by Mark Elliott to do this, I was slightly sceptical of the nature of this meeting. It has a marked global public health and respiratory infection perspective. But as Peter's made the case, COPD is a global health problem, and everyone's problems are different. Size, scale, nature, and what you have available to tackle them locally are different. This data from it's actually from Public Health, from NHS England and the British Lung Foundation, just to try and bit of our local perspective. So the UK, over 1 million patients, adults diagnosed with COPD. There are probably another 1 or 2 million out there without the diagnosis. Therefore, it represents a significant proportion of the adult population, certainly, and even more so locally. It's a frequent cause of hospital admission, over 1 million bed days, based on the NHS England information, and any of you who work in the UK in the acute care sector know that at the moment we're drowning at the front door, and admission avoidance or anything that can reduce hospital admission is to be welcomed. It's a significant cause of mortality in the UK. The Public Health England Lung Foundation stuff, it's the 5th most common cause of death, the 2nd most common cause of respiratory disease after lung cancer, so above infection and TB. And in terms of our performance compared to international colleagues, and again, it's difficult with comparing data from different countries, how it's collected, analysed, etc. But we were ranked with the 3rd highest mortality behind Hungary and Denmark, and 4 times that of France, a country with a strong smoking history. Bring it home even more locally, this is data from Public Health England. So Liverpool's over here, and if you look across the M62, the northern powerhouse, we have clear the north of England, across the M62 over to Hull, through Manchester, Leeds, etc., and then up to Newcastle. We have the highest levels of attributable mortality related to smoking and hospital admission attributable to smoking. This is a serious problem for us locally, and therefore whatever we can do to reduce that is something we should consider. Smoking has reduced in the UK. Apparently the figures are about 19% of adults smoke, but there's a clear north-south divide in this. So just to bring that home, just to reiterate, hospital admission and mortality, they're bad for patients, bad for relatives, bad for the system. If there's something we can do to alter that, we should probably look at it. What I've been asked to talk about in 15 minutes briefly is around non-invasive ventilation. So if invasive ventilation is delivery of respiratory support, ventilatory support from a ventilator via an ET tube or tracheostomy, non-invasive ventilation is the same but via some form of other temporary interface mask, nasal face, hood, or whatever. Long-term, the huge variety exists, and particularly for the long-term home use. But NIV. One slide about acute COPD, before we get on to the long-term side of it. In the UK, it's undoubtedly clear that in the last 15 years, provision of acute NIV services for acute exacerbations of COPD has radically changed what we do. It's changed outcome for patients. General hospitals are expected to have the provision of an acute COPD NIV service, and it's something we measured against the quality of care, for example. Is that service available, and is it doing what it's supposed to do? This practice-changing paper from Leeds from 16 years ago now, the provision of acute NIV in a ward-based environment for a subset of patients with an exacerbation of COPD, not the most severely unwell, but almost halved those reaching predefined failure criteria, reduced again but not significantly those who actually got into intensive care, and halved mortality 20 to 10%. So 10% absolute reduction, treating 10 people to save one life. It really has changed what we do, and in part contributed to the development of long-term ventilation services. Now, if they have their exacerbation and then go home and don't trouble healthcare, that would be lovely, but we know that an exacerbations are bad for patients and bad for the system, and an acute hypercapnic exacerbation is even worse for patients and again worse for relatives in the system. This data from Hong Kong would suggest that of those admitted with a hypercapnic exacerbation requiring NIV, that following up for 1 year, half of them are readmitted to hospital within a number of months, and the 1-year mortality is around 50%. So they don't just go home and are fine. They enter a spiral of attending hospital, worse outcome, more exacerbations, begetting more exacerbations, developing into a terminal phase of life. It's a significant step along their journey, a hypercapnic exacerbation. So long-term NIV is what I do as part of my job. It's grown hugely in the last 30 years. There's a large variety of conditions that we offer it to for a whole variety of reasons. So with studies, anecdotal observation, all manner of data, local experience, that patients benefit from it. So neuromuscular disease, Duchenne muscular dystrophy, motor neurone disease, obesity, chest wall deformity, kyphoscoliosis. I think that these all benefit from the control of sleep disordered breathing, nocturnal hypoventilation, the improvement, the maintenance of more normal blood gas tensions in the day, improved sleep quality, a reduction in infection rate and better treatment of those infections when they occur, a reduction in secondary care. So there's a whole group of patients out there with ventilatory failure who we feel are benefit from this therapy with an improved quality of life and improved quantity of life. So it's an entirely reasonable question to come along and say, does this have a role in COPD, I think? You've got a group of people with chronic lung disease, with chronic ventilatory failure, who are significant users of healthcare resources, and if that therapy exists in your healthcare system, does NIV and COPD have something to offer them? At one point, we're excluding those with obesity-related respiratory failure, obstructive sleep apnea, for example. These patients are getting it. They already get it through sleep services, either NIV or CPAP. They benefit from it, and they're probably getting it on the basis that they've got symptomatic obesity-related problems, heavy snoring, sleep fragmentation, daytime sleepiness. They're getting nocturnal support for all the standard reasons, and if you like, they happen to have COPD. So we're not talking about the obese patient. What we're really asking the question is, what about pure COPD? So patients who have no other obvious explanation for their chronic respiratory failure, ventilatory failure. Now, it's been said it's an area of uncertainty and trepidation. Uncertainty in that the data has been much debated, and trepidation in that a number of people, many people, worry about this patient group because of the numbers. If this is of benefit, our service is going to be overwhelmed by referrals, patients, setup, is there the money, the equipment, the staffing to try and even deal with the potential problem. I say the data's been debated for many years. There's a recent recent systematic review in the International Journal of COPD from a group in Birmingham, where they found 31 studies of randomised trials of a variety of forms over many years, which didn't show any clear benefit. But it seems like the sort of meta-analysis were actually just putting more and more disparate studies into it, muddies the water rather than provides any clarity. It's traditional to mention, at this point, a study from the UK, Meacham-Jones in the 90s, small, limited outcome measures, but the patients were adequately ventilated, a reduction in PCO2 with some improvements in the measures chosen. And the final thing to say is that whatever the uncertainty and trepidation, this is already happening. If you look at NIV service in Liverpool, if you look across in Manchester, talk to colleagues there, we are already doing it, offering it to patients with COPD for a whole variety of reasons. And if you go back to the Eurovent survey in ERJ in 2005, it was the most common cause of NIV use long-term in their long-term ventilation services across Europe, varies between countries, but it's already out there and it's already being offered. Whatever we think of it, the genie is out the bottle. Looking at the better evidence base, there are probably four things to note, four studies we should touch on in terms of informing where we think we might be right now. The first is an Australian study done by a group of NIV enthusiasts, a good group, people who are used to delivering NIV, and 4 centres. Important thing to note is they took almost 5 years to not manage to recruit as many people as they were hoping to recruit. The patients were stable, so these were not inpatients for an acute exacerbation. They were stable outpatients with severe or very severe COPD, awake hypercapnia, CO2s of more than 6, and they were on long-term oxygen therapy. So a stable group with significant COPD. They received NIV NIV and LTOT versus LTOT alone, set up as an inpatient in terms of your resourcing, and survival was the primary outcome. It was powered to try and detect that. On a positive, survival did seem to be improved. The tops of the survival curve for the NIV and LTOT, it appears survival's better until they come together at about 3.5 years. At the end of the day, if you like, these patients have a terminal disease, but survival was better as over the first 3 years of the study. That's good. But however, quality of life measures, a number of them were reduced for reasons which are not clear, but it appears quality of life measures were reduced. So there was a survival advantage that was perhaps more marked in those who actually used it for more than 4 hours per night in a planned protocol analysis, but at the expense of quality of life. So the suggestion was it was at the cost of worsening quality of life. The next study comes along from a Dutch group, again, highly experienced in the use of NIV and doing studies. Once again, you'll see they were aiming to recruit a certain number of patients, but it took them a long time to recruit 200 patients from over 40 hospitals trying to feed into this over around 4 years. 1 patient per hospital per year. That could be a criticism, but many of us find that broadly reassuring. I doubt we'll be overwhelmed by, if we stick to the published data, we're unlikely to be overwhelmed by suitable patients. So they recruit the patient. Different group. They were inpatients who'd had an exacerbation, recovered, been off NIV, but then were randomised to NIV or standard care, and they chose admission-free survival, so either time to readmission or death. And they titrated their NIV to achieve certain aims, to reduce CO2 overnight. So, but started as an inpatient compared to the Australian study. Oops. The survival curves on the left here is time to events, a readmission or death. On the right, it's survival, no difference between the two. So conclusion from them in thorax was, couldn't demonstrate an improvement in time to readmission or death by the addition of NIV to COPD patients with hypercapnia after an exacerbation and as an inpatient. So different to the Australian group, inpatients, no benefit. Then along comes the next paper, again from a group of clinicians who are highly experienced in the delivery of non-invasive ventilation, German group, who have a very particular high-intensity ventilation, so high pressures, volumes, backup rates, to achieve good ventilation, to bringing down PCO2 overnight, target reduction of daytime PCO2. So these people were well ventilated, but once again, took them a long time to find not as many patients as they were hoping to. But these were severe, very severe disease, and they were stable in an outpatient setting with more marked hypercapnia than the Australian group. So PCO2 of more than 7. They were started NIV to achieve their predefined goals, very resource intensive, on average 5.5 days to set them up with NIV. They're then readmitted 14 days, 3, 6, 9, 12 months for an average of around 3 days. So they're spending around 20 days in hospital in the year of the study to be adjusted, cajoled, encouraged, ensure that they're having the therapy delivered effectively. We couldn't do this here in Liverpool in terms of resources, I suspect. But the results are impressive. At the top, the control group, 1-year mortality 33%, 12% in those receiving NIV. Highly significant, statistically significant, and improvements in quality of life measures. So again, a stable outpatient group, more hypercapnic than the Australian group. Again, conclusion, NIV, targeted to reduce hypercapnia, improve survival in those with stable COPD. Once again, it took them a long time to find these patients. For the last few years doing this sort of talk, it's been traditional to say, and of course we're now awaiting the outcome of the UK HOT trial with interest. Now that started to come out. The primary outcome data was presented at the ERS, which I couldn't go to, but I was grateful to Paddy Murphy, who's a friend of mine, for lending me these slides and letting me present some of them. So this was a UK-based study, NIV and oxygen versus oxygen alone, led by Lane Fox Unit in London, trying to put together the things we may have learnt over the last few years. So an acute exacerbation, but then they go home. They were reassessed a couple of weeks later in the clinic. If they had hypercapnia of PCO2 greater than 7, as stable outpatients, they were screened and then randomized to either home oxygen therapy or home oxygen therapy plus NIV, and they titrated the IPAP to achieve a reduction in PCO2. So the idea was it was targeting a physiologic variable. They were followed up, and the outcome was admission-free survival. Oops, very quickly, almost there. They, as I suggest, they exclude those with symptomatic OSA. They exclude those with a BMI over 35, so they're looking to exclude those with another cause of ventilatory failure. They exclude those who are on NIV and unable to come off it in the acute inpatient setting. And that actually represents a lot of our real-life clinical referrals to our service. Patients are in a local hospital, they're on NIV, they've survived with it, but they just don't seem to be able to come off it. So they're targeting severe COPD, a life-threatening exacerbation, they're capturing in the recovery phase, they had marked hypercapnia greater than 7, not 6, no other cause of sleep disordered breathing, and they administered the intervention in the recovery phase to achieve physiologic aims. Again, screened a lot of people to find 116 patients. We acted as a local recruiting centre in Liverpool. My colleague Nick Duffy had to work really hard to find, I think, the 8 or 9 patients we actually included in this study. So once again, we were not, at the beginning I told you how common or how COPD affects here in the Northwest. We had to work really hard to find them, and Lane Fox worked really hard to get the patients into the study, practically offering to pay for their train fare to London to be assessed for the study. Primary outcome measure, standard care, the blue line, so admission-free survival, so admission for any reason or death. 50% of patients had achieved that aim by 1.4 months after follow-up. 45 days, 50% of the patients were either been readmitted or had died. It's not great. The outcomes are not great for these patients. It was improved by the addition of NIV to that treatment to 4.3 months. That is statistically significant, and Paddy would have suggested it's clinically significant. We can debate that, but it's certainly statistically significant that the addition of NIV to standard care improved the primary outcome measure. The secondary outcome data is not in the public domain yet. So, to round off before lunch, that domiciliary NIV and COPD, I say it's already happening, it is increasing, and it will continue to increase. We're not going to stop it. I think everyone who's involved in the service in any way, respiratory physicians doing the referring or those taking the referrals, We recognise there are undoubtedly some patients who benefit from the addition of long-term NIV to standard other therapies, and that there's trial data out there, there's anecdotal data, there's observational data, there's personal experience. We've all seen some patients who we think have benefited quite markedly from the addition of this therapy. The German data being the most marked supportive data. Nothing suggested harm, either psychological to them or carers or physiological. I think it's entirely reasonable that we should look at prioritise other interventions with lower cost or more broadly applicable to broader groups, particularly smoking cessation and pulmonary rehab, which I'm keen on. We're not discussing obesity. For the moment, we think we know how to do it. That would be higher pressures, volumes, rates, to achieve a reduction of CO2, bring down CO2 overnight, a proportion of time in alkalosis, improving chemosensitivity, hypercapnic ventilatory response. From the 4 trials that I've talked about, which are probably the best evidence we have for the moment, I think the numbers are going to be small. I don't think, if we stick to those criteria as the inclusion criteria for clinical practice, I don't think we're going to be overwhelmed by patients. So we're not going to have them in an acute admission. They're going to have to be persistently hypercapnic, and 7 seems as good a choice as anything for the CO2, on maximum medical therapy. And I do think we need to look at who adheres well. The physios, nurses who deliver this therapy are very sceptical about the COPD group, feeling that they don't really use it, they don't really tolerate, they consume a lot of time and effort on their part, they ring them up a lot, they're not using it. We as doctors think they've still issued with it and it's all going well. They're the ones who are taking the calls every 3 days because they've lost it or broken it or moved out of that house, they've got a chaotic lifestyle. So we have to look at who's adhering well and why are they using it. Is as much about their psychology, because many of them are using it to prevent a negative. They're trying to prevent them being readmitted to hospital or improving mortality. They may not get an obvious, rapid symptom relief from it, unlike, say, OSA or CPAP, such that it encourages their adherence. So what is it about the people who used it long term, like the German group, the people who put it on every night, despite it not necessarily making them feel a huge amount better, but it improved all these other things that didn't happen? Finally, I'd say if we do use it, we should be using it as a genuine trial. So if they take it away and have it, they use it for a number of 6 weeks, 3 months, whatever we choose. And if they're not using it, rather than keep readmitting them to retry it and try and persuade them, we say, we'll take it off you. Have it as a genuine trial. If you don't use it, we're going to have it back. And I don't think it's unreasonable to ask questions about cost and benefit, particularly in a global health perspective and even locally within a relatively well-off first world country. Thank you. Any questions?
We're almost through our time. Are there any questions for Dr. Parker just now? It's obviously a somewhat more esoteric area than perhaps the other 3 talks, but nonetheless I think is very relevant. I think there are some messages that come through in choosing treatment for anyone, that you've got to choose the right people. And just as a thought, Robert, I've always felt that persistent hypercapnia, despite having recovered from an episode, despite appropriate other treatment, particularly cardiac treatment, is the essence for selecting the COPD patient who might benefit. Would you agree with that?
I agree, and I think that the idea that the HOT trial, if they PCO2 of greater than 7 to meet the inclusion criteria, and I think the most common reason that the patients fell out of the trial at the screening point was that their blood gas on their 2-week reassessment, their CO2 dropped under 7. Their ventilatory failure had improved with a couple of weeks in the community and being a bit more active, and they were then excluded. So persistent hypercapnia seemed as much as anything a reason, should form part of, I think, the referral criteria if we're going to consider this and how we're going to see them in the clinic. Sorry.
Quick last question.
Yes, Christian Hessman from Borstel, Germany. Did you actually measure any functional tests, such as 6-minute walk tests, in the HOT trial to see whether they have functional improvement?
There's a lot of you mean the HOT study, the UK one? Yeah. If there's a lot of I'm not sure they did incremental shuttle walk test. So there are exercise data. The secondary outcome data that I'm not privy to at the moment is out there and will be, I'm sure, keeping them in business for the next 5 years, reporting it type thing. But yeah, there was lung function assessment, quality of life measures, and some sort of measure of exercise capacity through an incremental shuttle walk test. Certainly that's what we were doing locally.
We're going to have to wrap up there. Thank you very much for staying with us. I hope you've enjoyed this session. We've enjoyed talking to you. Thank you.